Dr. Piyush Kapur will give the talk on tackling the astigmatism and reshaping the cornea where we are off target. Dr. Piyush Kapur is a renowned cataract and refractive surgeon from New Delhi, and he is a prolific cataract surgeon and a very good academician. Dr. Piyush Kapur, please.
Thank you, Dr. Bhalla, for your kind introduction and giving me this opportunity. In my talk today about the precision in cataract surgery and trying to reach 2020, I'll be talking about astigmatism and how do we manage it. Well, first of all, I would like to specify that we should always target and treat any astigmatism more than about a 1 diopter, or rather now the precision is reaching up to about anything more than about a 0.75, for which we need a right clinical estimation of astigmatism. We need to review which lens would be the best for our patient, and also we can reshape our cornea without using a toric IOL. The main backbone of a treatment of astigmatism lies in the proper evaluation and the right estimation of the astigmatism. Mostly, my talk would be restricted to treating the regular astigmatism because they have the most predictable results, and we are rather not bang on, or we still cannot very well manage the irregular astigmatism. So in this, we have the whole plethora of instruments available with us, like the keratometry, the autokeratometers, the placido disc based, and the pentacam. The main important pearl is that either we take multiple readings on different occasions or we use the same instrument on different occasions. Like depending upon the availability, what we have with us, we can either take multiple readings on different instruments and make an average out of it, or if we have limited resource, we can take different readings on different occasions and actually be more sure of what we are dealing with. The K readings generally should not vary anything more than about a 0.5 diopters. And when we consider the X's, the variation should not be more than about 10 degrees. If we are beyond the scope, then there is something to be dealt with. The more accurate reading can be attained by tomography with the LED based light source, which can actually give the best possible posterior estimation of the astigmatism. And while dealing with astigmatism, now is the era that we deal with the total corneal astigmatism rather than just talking about the anterior or the posterior separately. And this is very well based on the corneal index, which has been specified in Dr. Bhalla's talk also, that we need to be specific that what refractive index of cornea we are taking, because this can also change our biometry or the alignment of the lens. It's very important that we need to have the right calculation of the posterior corneal astigmatism, which was not talked in the past, but in the present days, it is a must while treating astigmatism. As we know, most of the corneas have a little plus bar in the posterior part when we are talking about the horizontal meridian, as a result of which we generally tend to overcorrect with the rule astigmatism, and we can always undercorrect and against the rule astigmatism if we do not estimate our posterior corneal astigmatism. So newer generation instruments like the Antrion, the IOL Master 700 give us an insight into the total estimation of the corneal astigmatism. They give us the total K values, which is the way of calculating astigmatism on date. It can actually give us the right desired readings, and we can select our individual template. We can use the correct formulas which we need, like the Barrett suits and all, and get the proper biometry readings. So once we are done away with the proper calculation, we go on to the online calculators which are available, or we can use our instrument per se to calculate the alignment of the lens which we need to place. I generally in my practice use both the methods. I use my LensStar, I use my Antrion, and I also ask the company people whichever lens I am going to implant to give me the sheet, and I take an average out of it to just see that whether my accuracy is actually appropriate or not. ever if I have to err towards one side, I generally always go with the one calculated sheet which is given to me by the company guys, because I have seen that they have optimized according to their lens, and they actually are little more on the accuracy when we consider alignment of the lens. So having selected that where we are going to put the lens, it's very important to understand that which IOL design we need to use and which has got the best rotational stability. Like I have been using various lenses, but on date, the best choice with me is the Technistoric 2 platform, which actually has a kind of a better stability, because the edges of the lenses are just roughened up so that the rotation is minimal. And I have seen that with the newer Technistoric 2, almost we tend to get 100% result, and the rotation is very minimal in the post-operative course. So going on to the steps, how do we actually plan the surgery? I would say that first we do the toric marking. There is a small video which would demonstrate that how I in my clinic do the toric marking. We make the patient sit on the slit lamp, ask the patient to look absolutely straight by giving the distant target, and see the 180 marks on the cornea. Either I use a bubble marker or a single pin. Here, first I am using a bubble marker and getting the 180 and the 90 points aligned. And this is a single pin alignment where I just see the 90-degree mark and put it with the pin. Depending upon the patient cooperation, I generally select how to go about with it. Once having marked in the OPD, we take up the patient for the surgery, and on the desired axis, give the marks where the lens has to be aligned. I would not go on with the surgery because of paucity of time. Once the alignment has been done and a proper surgery has been done, the lens is placed on the desired axis. But sometimes these accuracies cannot be really attained. There is always a scope of error, and this was one of the case which I did, where the lens was actually present at almost a 90-degree rotation. And when I went back to saw the data of this patient, actually the optometrist who had calculated the K values and given for the toric alignment had just reversed the 180 and the 90, and we landed up having the patient being placed the lens accurately, but it was at a 90-degree misalignment. This was 2 weeks post-operatively, but we went and realigned the lens by just lifting the rex's margin a little, because the lens gets the capsule gets adhered to the margin of the lens, injecting a little viscoelastic in the bag to separate the lens from the capsular margins. It's very important to be patient in these realignments, because if you are a little too aggressive, you can land up in tears. Yeah, I'll just summarize, sir. Once we have realigned the lens, then I would just talk about how we can reshape the corneas when we have to deal with the astigmatism. And generally, I would say reshaping the cornea can be done for anything between 0.5 to 1.5. The incision can be aligned at the steep axis. For 0.22 incision, I generally give a SIA of 0.15 to 0.18, and when it is as big as a 0.55, it can actually treat up to about a 0.5 astigmatism. Whenever the astigmatism is anything more than a 0.75, we use the LRI. Here is an LRI which I had given with a flax for a patient which we implanted with a VVT lens. And whenever the astigmatism is less than a 0.95, I generally use a double CCI if the patient is not affording a flax. And if at all we are not able to reach bang on the target, we have bioptics with us, which is, I would say that the surgeon should never be very aggressive, and if we are very close to the target, I generally discourage any such thing.